that. So thank you very much for joining today's RISE Lunchtime webinar. Today we're going to be talking about working with an attributed population. We had 18 meetings across 6 communities, regions, I should say, over the last couple of weeks. And one of the things that bubbled to the surface in virtually every meeting was working with an attributed population. So we know that our colleagues at the ministry, along with Rick Glazier, talked in a ministry organized webinar about how the attributed populations were calculated. But we wanted to, in response to some of the feedback that we were hearing in different communities, just talk very pragmatically about some thoughts about how to work with an attributed population. These are just thoughts that have come forward through the OHT community of practice that seem to us eminently sensible, but we'd love to hear from different folks that are participating today about how they are working with an attributed population. So we'd encourage you to consider posting in the OHT community of practice any additional thoughts or any reactions to what you've heard today. So this is the third in a series of 6 webinars that we're doing in the lead up to the full OHT application being due on October the 9th, working with an attributed population. And as with all of the others, a recording of the webinar will be posted on the RISE website under Join Events. So that will be done within a few days of today's webinar. So this slide is just a quick overview of some of the topics that we're going to be talking about in the webinar today. So these are different ways of thinking about how to work with an attributed population or different issues that come up when working with an attributed population. So the first point is really about partners, and as many of you now know, the map that you've received if you've been invited to full application, or that you will receive if you're a team in development, is absolutely critical. But you'll also see a comment there in brackets. We're not aware of a current plan to share or make public all of the maps for the province of Ontario. So we'd strongly encourage you to think about sharing your map with others, because it's so helpful for people in adjacent communities to be able to see the maps that individuals are working with. So 31 teams currently have their maps, and then the 41 teams that are in development will be receiving their maps, and making those available at the individual team level would be very, very helpful. Second thing is to consider whether or to confirm that you have an appropriate scale. So we're going to be talking a little bit about some of the considerations in deciding whether you have a workable size in your attributed population. Third point is to identify and prioritize your work with your year 1 priority population. So in past webinars, we've talked about those year 1 priority populations in terms of the patients or the attributed population. But here, what we're going to focus on is focused on the biggest groups of providers. So how to think about which providers to be working with in year 1. The next point is about the fact that as you start to move into implementation for teams that are invited to full application and then ultimately become candidate Ontario Health teams, they will want to quickly start to operationalize some of the population health management principles that Rob Reed talked about last week. And at this point, our advice would be don't yet purchase off-the-shelf solutions. It's likely to be the case that some of you are already being approached by vendors from the US and other environments with off-the-shelf solutions, but we'll come to the fact that chances are, in the coming period of time, some of those solutions will become usable in Ontario in ways that make it much more feasible for all of us. And the final point is just about being pragmatic in some of your early work on home care, and we'll elaborate on that when we get to that. So we just have one panelist today. We had a number lined up, but unfortunately a number of events happened on the weekend that meant that people that we were expecting today couldn't join us. But we have Rob Reed, who's going to be making some observations about Mississauga's attributed population, and we still have a map in from one of the teams that we were planning to have as panelists. So we've removed a little bit of the content because of the shift in panelists, but we still have one map that we'll use to illustrate some points. So the first piece is about starting with your map. So I'm sure that you've either heard us or others say that the maps that display naturally occurring utilization and referral networks are a critical input to teams defining their target population. So the key thing about these utilization and referral networks is they reflect where Ontarians are currently obtaining care and where their providers are currently based and to which hospitals they refer for admissions. So the nice thing about working with these networks is they reflect where Ontarians are currently going for care. So teams invited to full application can use their map to confirm their partners. And you'll see two examples of maps today. So if you haven't previously seen one, it will give you a feel for how the map can help you confirm your partners. Teams in development who will receive their map as part of their data package in the coming weeks can use the map then to confirm whether they are or can become well aligned with a naturally occurring utilization and referral network. So that's an absolutely critical step for teams in development when they receive their map. So we're going to be talking today about the maps that are being provided by the Ministry of Health based on the methods developed by ICES. There are other maps that you'll hear people talk about. The Ontario Medical Association has a superbly helpful interactive map of teams invited to full application and teams in development. So that might help you identify other teams nearby that you could approach both to share your own map and to ask if they would be willing to share theirs. There are also groups like thehealthonline.ca who provide a map of services. They have many ways that they can display services in terms of geography. One of the ways, the most common way that people currently use it is by local health integration network, but it would be relatively straightforward for them to reconfigure all of the data that they already have to meet the needs of teams. So as you begin to think about having a website for your Ontario health team and wanting to use that site to help with system navigation, that might be a very helpful resource that you might want to think about. And there are other providers like Empower Health that provide other types of mapping tools. So this is the map of perhaps one of the simpler cases. So this is a map for the Couchiching team. So the first point to note here is that patient enrollment models are key to attributed populations. So as I'll come to in a minute, about 82% of Ontarians have been attributed to a network based on enrollment in some kind of patient enrollment model. So in this particular map, these are reflected by the dark green circles. So you'll see one just under the H for the hospital in Orillia, and you'll see another just under the city of Barrie in the lower left. So that's driving a big chunk of the attributed population for this particular team. Community health centers and nurse practitioner-led clinics have then been added to the map that was shared with this team for illustrative purposes. So you'll see two community health centers on this map, one very close to Barrie, the Barrie CHC, and one on the other side of Lake Simcoe, the Brock CHC. You'll also see a purple square off to the left, not labeled, so above Barrie and to the west of Orillia. And that is a nurse practitioner-led clinic. So those have been overlaid onto the map just as reminders of other primary care providers in this area. Other primary care providers could be added, both at the level of individual practices and walk-in clinics, for example, similarly for Aboriginal Health Access Centers and interprofessional Indigenous primary care teams. If you added those, then you would be rounding out the picture of where primary care providers are based in your area. You could also, though, add to the map home and community care providers, long-term care homes, French language service providers, etc., to get a better feel for some of the other sectors in terms of where they're physically located. Municipal boundaries could be added as well, and we'll come in a second to an example where a municipal boundary has been used in a pictogram just for many reasons, but one of which is to remember that municipal governments often have access to many human services, to supportive housing, and other things that could very much benefit the patients attributed to a local team. And finally, you could also superimpose on the map the place of residence of the Ontarians that have been attributed to this network. So you have to remember that these maps are showing where the providers are located. They are not showing where individuals reside who are seeking care from these providers. So that's, in a way, the easier case, Couchiching team. Just 2 patient enrollment models, just 2 CHCs, 1 nurse practitioner-led clinic, and you'll see just 1 hospital is showing because the primary care providers largely refer to that 1 hospital. So we're now going to turn to Mississauga Ontario Health Team, which has a much more complicated picture. And because of that complexity, they've come up with a pictogram that they are using to communicate with providers and community members so that people can understand what the attributed population means for that community. So with that, I'll turn it over to Rob, both to talk to this pictogram and then to talk to the next slide, which is their far more complex map with their attributed population. So Rob, over to you.
Yeah, John, I imagine you can hear me. Let me know if you can't. But thanks for the introduction to that. I think the Mississauga is very similar to the other map that you've talked about, but a little bit added in terms of a complexity given the circumstances at Mississauga. And I'm going to talk a little bit about how the Mississauga Ontario Health Team is thinking about their attributed population, and that may be helpful for other Ontario Health Teams as they think through how this actually maps out. Every Ontario Health Team has different challenges and different types of populations situated in different ways, and this is the way that Mississauga is thinking about moving forward. As you know, Mississauga is a large city. It's actually the 6th largest city in Canada, and it serves it's a growing city. So there's a lot of new immigrant populations coming into the area of Mississauga. And it butts off really next to 3 other large urban centers, Toronto, Brampton, and Oakville, and therefore there's a fluidity of the patients and providers across this kind of continuum of an urban-suburban sector west of Toronto. Mississauga has 1 large hospital that is one of the largest hospitals in Ontario. And it serves not only the people that live in Mississauga, but also many of the people in the surrounding area, either with core services or many of its regional programs, such as cancer, renal, stroke, and so forth. So as the Mississauga Ontario Health Team is trying to understand its service perspective for the attributed population, it used this diagram, which I thought was actually fairly helpful. So the first, if you look at the different segments of the population here, you can see that the first one is actually the group of people who are part of the attributed population, and the attributed population, again, here is very large. These are the people who live in Mississauga and actually receive care, primary care at Mississauga, particularly through the patient enrollment models or the fee-for-service physicians in the locality here. And that ends up being the majority of people in the Mississauga attributed population. Over 60% of people that are attributed here generally live here and receive their care through their primary care physicians here. Number two is actually looks at the fluidity of this movement across a region like Mississauga. So these are people who are rostered to physicians in Mississauga, but actually don't live in Mississauga. They live in surrounding communities, but they seek their care from a Mississauga PEM or fee-for-service primary care physician. Number four is, I'll jump over to number four. These are people who are rostered with physicians, but those physicians and those patient enrollment models aren't actually in Mississauga. They're also in the neighboring communities. And so the linkage with these physicians is not as clear as with the physician groups that are actually in Mississauga. And then I wanted to point out the two other groups here that are important to consider. One is the proportion of people who live in Mississauga, but actually aren't rostered anywhere. So when you're thinking, and we talked about this with a population-based management strategy last time, these are the low users or non-users of the system. And what we're trying to do with this system is make sure we're continuing to serve them and prevent their use going forward. The fifth one is also important to consider, and these are people who live in Mississauga, probably attain their care in Mississauga, but actually aren't insured by OHIP. And these ones in a community like Mississauga are often new immigrants coming here who have not yet signed up for OHIP, and yet they're a service sector that the Mississauga OHT considers important to be able to include. And then finally is this last segment of people, as labeled as number 6. Those are the people that live in Mississauga but actually obtain their care elsewhere. So these are people who may live here but to seek their care in Toronto, and so therefore they're actually enrolled attributed to another OHT, not those here. But I think the group wanted to make sure that they had everybody on this spectrum that touched Mississauga and the Mississauga OHT in some direction. Okay, so let's move to the next slide. So if we take this conceptualization of the people and where they live, this now looks at the Mississauga OHT map. And you can see, as in the prior map, this one you'll see 2 hospitals. Actually, it's the same hospital, 2 sites of that hospital located in the core areas of Mississauga. And you'll also see a variety, and quite a few of them, PEMs that are associated with that attributed population that are in the geographic boundaries of Mississauga. So that this group of PEMs and the attributed patients with them are those groups that I talked about, those patients that live in Mississauga or those patients that live outside of Mississauga and actually seek their care from a physician or a physician group within the Mississauga boundaries. Then you'll also see a variety of the community health centers. And what's interesting in the community health centers is there actually are no community health centers except for 2 very small ones that are actually in the Mississauga boundaries. Those other community health centers are actually in Toronto and Brampton and in the neighboring communities that surround it. And then finally, you'll see a lot of other smaller physician groups, all other PEMs. And these ones are scattered in Toronto and in Milton and in Oakville and in Brampton, that those patients are assigned to the Mississauga OHT because that's where the referral for those physicians lies, is in coming to the Mississauga hospitals. So it's a bit of a complex overlay for Mississauga about people who live here, get their care in Mississauga, as well as those that receive their care live and reside in other places outside of Mississauga.
Super. Thank you very, very much, Rob. So Mississauga's map, particularly in a way complex, and that team, like others, is noodling through how to think about this going forward. So let's move on to just starting to think about a workable size. So there is no guidance about what would be an optimal size for an Ontario health team. What we have found coming up in conversations in our interactions with teams are two thoughts. So the first is for teams in development and in discovery, many of which tend to be on the smaller side. And so here what we're finding in conversations is helpful is to think through the factors that help them work through whether they have or can have a population size that would be workable as a team. So all of these factors are factors to think about, would you be big enough to address this? So the first issue is that performance measurement, which is OHT building block 8, requires quadruple A metrics that have a reasonably small confidence interval. You don't want to become accountable for a metric where a small number of patients could ultimately dramatically affect what your metric looks like. And so there is some benefit to being on the larger side in terms of performance measurement. Second consideration is that at least two of the building blocks for as complex an undertaking as creating an Ontario Health Team require a great deal of capacity. And the two that have come up over and over among the OHT community of practice are leadership, accountability, and governance, and digital health, especially data analytics. This does not mean that there are not superb leaders, that there aren't superb data analysts in even small communities, but an OHT is a remarkably complex multi-sector body that will require extraordinary amounts of distributed leadership and will require quite advanced data analytics that I think will test even the largest of the team. So those are two building blocks where people have said time and time again, capacity is going to be absolutely essential. And the third point is that what has come up often in conversations with members of the OHT community of practice is that there are likely economies of scale in designing other building blocks. So there are activities like community engagement, initiatives like those focused on health literacy support, and a whole array of issues related to contracting, where it probably is the case that it becomes easier to do these things the bigger the scale. So again, none of this is to say that you can't have a team that is on the smaller side, but that there are considerations that might lead you to say we don't want to be too small because of these factors. The flip side of that is that teams invited to full applications that have very large attributable populations may also want to work through what population size is workable in year one. So obviously, all of the participating members of a team are going to continue focusing on providing great care for everybody. But for those year one priority populations, what is a workable size that can be engaged, especially with primary care providers, as those trusting relationships are being built? So this slide speaks both to being big enough, but also making sure that you don't launch too big and take on too much in year one. If I jump to the next slide, these are just for illustration purposes. Again, there is no guidance about what the optimal size is, but when we look at the distribution of the size of the attributed populations for the 31 teams invited to full application, if we take those 31 and put them in order from smallest to biggest, the middle one has a size of 219,000 people. The mean size is just shy of 300,000. So the mean is bigger than that median, meaning that there are a number of teams that are much larger that are pulling up the mean. If we look at the 5 smallest, they all range between 54,000 and 100,000. And if we look at the 5 biggest, those are all larger than 500,000 people, and 2 of them, of which one is Mississauga, which we just heard about, is larger than 870,000. So that just gives you a bit of a feel for where the kind of center of gravity is, and then where the smaller ones are and where some of the bigger ones are. So again, no right and wrong answer here, but on the previous slide, some things to think about when you're thinking about size. Now, if we move on to next steps, one of the things that many people have been grappling with is how do we begin to work with these people? We don't have the roster of who these individuals are. We expect that at some point it will be the case that we'll have a population attribution algorithm so teams can use their own data to regularly generate a patient register for which they're accountable. So again, there is no current plan that we're aware of to at any point share an individual listing from the ministry to teams. But one can imagine easily using the methods that were used to generate these attributed populations, that with the right algorithm, the teams could approximate the creation of that patient register. But in the meantime, we think it makes sense, and what we hear that people are doing in the OHT community of practice is start with the biggest and most relevant group of providers in order to move the needle for year one priority population. So those are the patients rostered to a local primary care provider. So those are the PEMs. On average across Ontario, they account for about 82% of Ontarians. So another way of saying that is 82% of Ontarians have been attributed to one of these naturally occurring networks based on enrollment in PEMs. The next group that you could consider prioritizing, which will get you an additional 16% of Ontarians, are patients attributed based on frequent visits to a local primary care provider. So for those primary care providers not in a PEMS, chances are they know which patients have been coming in a few times for primary care services, and chances are those individuals have been attributed to their local network. So between the 82% from PEMS and the others who we know are already going in to see local primary care providers, you get at a very, very high percentage of Ontarians. What would be much more difficult would be to identify that extra 2%. So in year one, as with all of this work, teams are trying to find ways to move as fast as they can. So starting with the PEMs and secondly with the patients already seeking care from local primary care providers that are not part of PEMs seems like a logical place to start. Two other observations about this. One is be creative in how you can augment services for those who live locally, and this is the rationale for doing things like superimposing municipal boundaries, because when you start to do that, you can then see that individuals who are rostered to a local network and who live in that local community can also benefit from a array of housing and other human services that municipalities are able to provide. And another consideration that members of the OHT community of practice have brought to their attention, and we'd certainly over time want to see robust research evidence about this, but the observation is that non-local members of your attributed population are likely to skew healthier. So these could be working age commuters who are moving from one community to another during the workday, and as a result have chosen to enroll with a local primary care provider or to seek care from a local provider, and similarly university age students who for a chunk of the year might be in a different community from where they might officially reside. So those are just two other observations about the biggest groups. The other points are a bit more straightforward. This might not be on some of your radar, but through the OHT community of practice, we hear people sometimes worrying about whether they should be purchasing off-the-shelf solutions that are available through vendors, often US-based vendors, for a population health management system that would allow you to put in place reminders, prompts, and other things that support the types of in-reach and outreach services that Rob spoke about last week in his session on population health management. But our sense is that over time in Ontario, we are likely to move to some type of system of that type, or it is also the case that as people purchase new hospital information systems, new electronic health records, these often already contain sophisticated population health management systems. So as you heard in the Digital Health Playbook webinar, I think it was last week, be cautious about these kind of purchases. There is a good chance that there are going to be scalable things already in place and or more easily scalable opportunities coming down the pipeline. Final slide is just about being pragmatic in early work in home care. Again, some of the things that have been coming up in our interactions with members of the OHT community of practices, uncertainty given, what the future of home care is going to look like hasn't yet been identified. And what we hear from a lot of people is just about the importance of being very pragmatic. Stay flexible in terms of the partnerships with home care providers that can or could service your attributed population. And remember that the focus for the year one populations is really co-designing initial in-reach and outreach services and care pathways that include home care, but can operate within existing home care arrangements. But as you're working that through, if you have thoughts about how those home care arrangements could be made even easier, then that's exactly the purpose of Appendix A. It's an opportunity for you to share your thoughts about how those in-reach, outreach services, how those care pathways could work even better if home care were to evolve in particular ways. But for now, with your year one priority populations, you're operating within existing home care arrangements. So just a reminder that much of what we've talked about links directly to the focus of last week's webinar, which was also the focus of RISE Brief 6 about population health management. So if you haven't taken a look at that, we'd encourage you to do that. So we'll now open it up. We'll see if there are any questions, observations that have come in. Just a reminder that we're audio recording the session. It'll get posted on the RISE website. If you have very specific policy questions, please direct them to your ministry point of contact if you're part of a team. And if you have very specific questions about how these referral networks were constructed, the original paper from ICES is on the RISE website, which you can access. But if it's something very particular to the maps or the data package you've received, or in the case of teams in development will soon receive, we'd encourage you to contact, again, your ministry point of contact. We'd hope to have Neil and Jenny on the line today to answer questions, but they weren't able to join us. But you can always get a very quick answer from both of them who know all of the methods that went into this. So Carrie, I'll turn it over to you to see if there are any questions or comments for Rob or myself.
Sure. So we have a few. There's two that are related to the maps from slide 6.
Yep.
One of them is how, with reference to slide 6, how can we add the items 3, 4, and 5 on our map? And those items are home and community care providers, long-term care, and French language service providers is number 3. 4 is municipal boundaries, and 5 is place of residence could be added for insured patients.
Yeah. So Steve, can you give me control back over the slides, or can you just jump back to slide 6?
You should.
Or Carrie?
You should have the control right at the moment.
Yeah, you do, John.
Oh, okay. Sorry. So, but I can't seem to go back. I can only go forward. Yeah, it's not letting me. But anyway, so I mean, I'm not the mapping software person. So I think that Rob might be able to speak to this. Mississauga may have found a solution, but over time, I think what will happen is we'll end up starting to work with mapping software that everybody has access to and much more easily do this. So I don't have any quick tricks. I would just, these are the types of things that in many local communities, where these different types of providers are, and you could, map it on physically in the short term. There is, of course, software that helps a lot with this type of mapping, but that's certainly not an area that I know very much about. Rob, has your team spent time trying to adjust the map it was given and or gone down any other path to better display the array of local providers?
Yeah, thanks, John. I think, I think with our team, or the team here in Mississauga, is trying to sort of round out those maps so that they do actually reflect the entirety of the care trajectory here. And the first that was the easiest to insert were the municipal boundaries on top of those maps, because that is actually fairly straightforward to do, given you actually have those maps with many of the roads and that sort of thing on them already, so that is an overlay that could occur. The overlay in terms of the public health units is also an overlay that can occur in terms of how those regions intersect with those maps, which is relatively straightforward to do. And then, at least for the team here in Mississauga, they actually knew many of the, particularly from the old work with the LIN, about where many of the other types of resources are located in this community, particularly long-term care facilities and the like. So that those existing maps that the LIN in this community had created were overlaid on those. So I think we can continue to build them out. One thing that I think everybody would like at some point is to know actually where the patients are in terms of where they live and reside, in addition to where the service providers are.
Absolutely. Thanks very much, Rob. So sorry, we've now got back to this this slide that shows the things that we're suggesting could be added. So these are just our personal observations about things that might be helpful. And as I alluded to before, the healthonline.ca would be an example of a service that has all of the service level data about where these providers are located, and then very powerful mapping tools. But where we obviously want to be over time is people sharing their experiences about what would be helpful, and then finding ways to very efficiently provide those types of maps for all teams. It would be a shame for everybody to reinvent the wheel, and that's a key part of what we're hoping to achieve through the OHT community of practice. People sharing innovations, like the example of the pictogram that Rob developed, and then others can easily build on those. So, Carrie, did you say that you had another question lined up?
Yes, there are plenty coming in. So the next question is, it sounds great that PEMs account for 82% of the attributed population, but I gather there's significant variability. In some OHTs, PEM contribution seems to be much smaller. In urban centers, the attributed population is hard to pin down and seems to be dispersed. What are your recommendations for working with these attributed populations in urban areas?
Yeah, so, I guess it is, there's no question it's challenging, particularly in the most, complex urban areas like downtown Toronto. But, by and large, in a given area, it's where people are currently going for their primary care providers. So if you are in a community with a very low percentage of the population in PEMs, then it comes down to then for the remaining primary care providers who is currently seeking care from them. So someone was telling me that, they've heard Rick Glazier say many times, primary care docs know who these people are. These are the ones that are coming in and seeing them. Whether or not they have a rostered population, they know who are coming in their doors, and those would be the focus. So I agree with you very much that the 82% in PEM, 16%, those are averages across the province, and they will vary by community. But the low-hanging fruit is initially the PEMs, even if that percentage is lower than 82%. And then the second is those folks that are obtaining care, multiple times from a local primary care provider. We don't know what the cutoff point is, but again, if I were designing an algorithm, over time, that would be one of my first questions. What is the number of visits, 1, 2, or something that typically triggers someone to be attributed to my primary care practice compared to someone else's. So again, we're not going to, nothing, in year one, we're trying to move as fast as we can, and the way to move the farthest, the fastest is start with the PEMs and then move on to the non-PEMs, but the patients that are seeking care from those primary care providers.
Yeah, John, I'll just add into this, and that was one of the reasons that we chose Mississauga as an example today, is because of the fuzzy boundaries and the movement of people in and out of the Mississauga community with Toronto, Brampton, and the like. But even in a place like Mississauga, where there is terrific shifts of people the majority of people that are attributed to the Mississauga OHT actually reside in the locality of Mississauga with those PEMs. And so even in a place like Mississauga, which has those very fuzzy boundaries, it is a practical approach to start with the local PEMs to try to really develop what your care models look like, to be able to understand how this OHT will work, and then at least in the Mississauga population, gradually expand from there.
Thanks very much, Rob. Carrie, back to you for questions.
Great. So would you have any insights regarding decreasing confidence intervals in large northern territories where clinical network populations are smaller? How can they best work towards the quadruple aim in this environment?
Yeah, so, I think it's a great point. So, those considerations that we provided all obviously need to be tempered by, those other realities of life in more rural and remote communities. So, our main point here is just to be thinking that it could be the case that a very small community in the north might think, well, we have this kind of naturally occurring network, and so it makes sense to think of that as where we start and we stop. But some of these considerations might lead them to think over time, okay, maybe we need to be thinking about joining forces with an adjacent community, if only to share eventually kind of back office support in areas where, it's going to be hard to replicate the leadership structures, the data analytics, and other things. So I think it's always going to be a balancing act in more rural and remote communities about what makes sense in terms of the pragmatics of a reasonable sized network versus what might be optimal when you're thinking of how complex it will end up being to run a team. So, I think the biggest challenges in terms of community size are the very small, probably, and the very large. So Rob provides that example of the very large with the fuzzy boundaries, and then there are going to be many smaller communities. So I don't have any great answer other than, this is just pragmatic, all of us noodling towards what is going to make sense. And, in many of the regional sessions, what has come out is, why not just give guidance? But the lovely thing about this transformation is that we're able to kind of think it through collectively. And so folks in rural and remote communities can think through, what are the benefits sometimes from joining forces with a more, a more distant group versus what are the benefits of staying smaller, and then what are the workarounds for very pragmatic issues like performance measurement. So I don't have the solutions now. What we're trying to do with this slide is just get people thinking explicitly through these considerations, and then once people lock on to what is going to be a workable size for them, then we know what kinds of issues like performance measurement are going to need to be worked through after that.
Great. So two more questions that have come in. One is, does your model consider those who are local but seek or receive specialized services elsewhere?
So the attribution, I'm trying to go to Rob's slide. The attribution is primarily, I can never go back. So unfortunately now I've gone forward, I can't go back. The attribution is driven by primary care providers. And remember that the intent of teams is that they will cover the spectrum of care and with a particular attention in the early days to home and community care, primary care, and acute or hospital care, but not the most highly specialized care. So it's still not clear how teams will intersect with that. That is something that will get worked out in future. But what teams are meant to be focused on is that array of more routine home and community care, primary care, and more general acute hospital care. The most highly specialized stuff has been flagged, at least in my understanding, as something that will be dealt with separately through more regionalized and provincial approaches, which have yet to be fully defined. So the important thing to know with attributed populations is what drives attribution is largely primary care, and then the local hospital is where those primary care providers typically refer, but highly specialized will be dealt with in a different way.
Great. So our last question is, can a PEM be associated with multiple OHTs?
That's a good question, and one of those ones that I wish that Neil and Jenny were here, because I recall having heard them answer, but I can't recall what the answer was. Rob, and it might be better that we defer to them and we can send out an email about that. But Rob, do you recall?
I'm afraid I might get the answer wrong to that one, so I'm going to defer to that one too, John.
Yeah, so I apologize because I've heard the question asked of them, but I cannot recall the answer. So we will seek clarity about that from Jenny and Neil, and we'll work with Steve. I think probably the easiest thing is in a follow-up email with folks who registered for today's session, we can get that answer back. And I believe Jenny and Neil have a running list of frequently answered questions, and if that's right, then they can update that on that frequently answered questions list on the ministry website. I know there was one other question, Carrie, that came in specifically to the panelists, which you might not have seen. Someone was asking about adding public health units to the maps, and absolutely that can be done. Of course, often the geographic coverage of a unit is often very specifically the municipality. That's the way those typically function. So the municipal boundaries would also give you a sense of the coverage for those public health units, but the physical location of a public health unit could absolutely be mapped on, and it is the case that they are sometimes providing services, direct access to services, so those could be mapped on as well. By these illustrations we provided, we just wanted to get people thinking about how what they're seeing in the initial maps are what largely accounted for the attributed population, which are the PEMs. And then what they're seeing is the hospital to which those primary care providers typically refer. And then the ministry illustrated with superimposing two other things, CHCs and nurse practitioner-led clinics, how one can superimpose then other types of providers to start to build out a fuller understanding of who is providing, in that case, primary care. But what we are pointing out is you can also do an overlay with other sectors, and that would include public health and the public health units.
Right, so we've actually had a few more questions come in.
Okay.
I think it's also maybe to add to the question that comes over to Rick, but once the ISIS assessment was done, how were the networks formed, i.e. how did ISIS come up with 80 networks instead of say 50 or 100?
Sorry, say that again. What was the second to last sentence? It was something about how were the networks formed?
So the question was, once the ISIS assessment was done, how were the networks formed? How did they come up with 80 networks instead of say 50 or 100?
Yeah, so I'm not sure. So, I mean, these are naturally occurring networks. So my understanding was, they're empirically defined. What I don't know is whether there were any rules set, about minimum network size that might have caused them to combine some smaller naturally occurring networks. So that's unfortunately an answer that I don't have. I'm pretty sure, again, it's a case of I feel like I've heard the question asked and answered before, and it might have been that it was on the ministry webinar, but I don't have the answer off the top of my head. So we will again confer with Neil and Jenny and get that answer. What we've tried to focus on here today is less the methods and less the questions that were already addressed in the presentation by Neil, Jenny, and Rick, and more on the pragmatics of how to get going in year one. As I mentioned before, in so many of our 18 meetings across the 6 communities, this issue came up time and time again. And it felt like many people were kind of losing sight of some of the big picture points that, we will over time in Ontario get more and more used to working with attributed populations. We will more and more be able to get a better handle on which particular patients are involved. In the short run, though, the big messages are that the maps are absolutely critical, and the more that people are willing to share them, the more that people in adjacent communities will have a sense of what is the optimal path for them, that people need to be thinking about what is a logical size that balances, the trying to be as close to the community as possible while being big enough to take on the complex tasks involved in a team. And that when you start in year one, what really matters is where people are currently receiving their primary care. And you get a long way by focusing initially on the patient enrollment models, but then you can immediately move on to where are patients currently getting their primary care? Which doors are they knocking on and receiving care through? So as Rob was talking about with the fuzzy boundaries and the complexity, you can quickly get kind of bogged down in the detail. But if you stay focused on the big picture, that this is largely primary care driven. Primary care docs know who their patients are, and those are the ones that really need to be the focus in year one. Lots of nuances can come later, and Rob's pictogram, helps you to understand what some of those nuances are, but the big picture is primary care docs and nurse practitioners and other providers of primary care know who their patients are. That's where you need to start in terms of working with an attributed population.
Great.
Anything else from you?
Yep. So one more here. Is there a current plan to provide more detailed geographic localization available for attributed populations?
So I'm not aware of any, but, as with all of this, the ministry is learning about what needs to be done, and we're learning from different members of the OHT community of practice what would be helpful, and we're encouraging people to bring those messages to the ministry, and we're passing them on as well. So I think it's likely to be the case over time that we come up with solutions that allow every team to benefit from excellent mapping that helps them better understand their attributed population and the current distribution of providers and services in their communities. And again, the focus now is what are the things that we can do to get as far as fast as we can together, and over time things will increasingly get more nuanced and so on. But for now, what we're trying to focus on in this webinar is some of those big picture points, so teams can move as far as fast as possible. But over time, I certainly would expect that we'll get increasingly sophisticated models, mapping, algorithms, other things that will help teams work with their attributed population in the most efficient way possible, ideally with solutions, that are scaled across the province. So regardless of your team size, your population size, and so on, hopefully everybody will have similar access to similarly useful tools, algorithms, maps, and so on. Anything else, Carrie? Or I think we're out of time. Would it be okay if we wrapped up? Great. So, Rob, do you have any parting comments, any corrections on anything I've said, or anything else to add?
No, I think you've done a terrific job, John. And just to emphasize that, this is a journey and we need some practical ways forward, and focusing on, looking at your attributed population and then really narrowing down on some of the PEMs in your local network as a way to get started. It seems entirely sensible to most OHTs.
Absolutely, and just to pick up on that point, we're finding it so helpful to learn from those members of the OHT communities of practice that are sharing their lessons learned, and that's what we've been trying to pass on to you today. And we'd encourage folks to contribute to that OHT community of practice. And also, if you're willing to make your maps available publicly, ideally, but if not, at least to adjacent teams working in largely similar geographic areas, again, I think that will help us get farther faster if we work together on this. So thank you very much, everybody, for joining us. I don't know if I still have control over the slides. I do. I'm just going to point out that we're just having a follow-up conversation later this afternoon just to confirm the topic for Thursday the 19th, but we know that for Monday the 23rd, we're going to have a session on engaging and improving care for Francophone populations, and on Tuesday, October 1st, we're going to have a webinar on taking steps towards collaborative governance. So if you haven't registered for those already, please do, and the recording from today, like all of these webinars, will be posted on the RISE website. So thanks very much, Rob, for joining us. Apologies to all of you that we couldn't get some of our superb colleagues like Neil and Jenny online to answer questions, but we'll communicate back to you by email with answers to those 2 questions that were posed today. So thank you very much for joining us. Bye-bye.